Okay, the topic is use of sodium bicarbonate in ICU, use as per guidelines. I don't think we should use sodium bicarbonate apart from the guidelines. So what is a guideline? So guidelines are made for us. Guidelines are the best available scientific evidence combined with expert consensus, which are used mainly to improve the quality and consistency of patient care. And they are here to make us, the clinicians, treat clinical decision making, tough clinical decision making. And they promote evidence-based practice so as to optimize the patient outcome. So this is about a guideline. So we have guidelines basically to help us out in difficult scenarios. So we have a scenarios where we use sodium bicarbonate, where we have a scenarios where we do not use sodium bicarbonate. So let's see some of the guidelines regarding the sodium bicarbonate. This is the European Resuscitation Council guidelines in 2025, which was released just 2 weeks back, where they said that use of soda bicarbonate in cardiac arrest should not be used. Okay? And the ERC specifically says that the routine administration of sodium bicarbonate during cardiac arrest should not be used unless there is a specific indication like poisoning with tricyclic antidepressants. Similarly, we have the American Heart Association, which has been giving us the guidelines from time to time. And in 1976, they said that sodium bicarbonate should be used during cardiac arrest. 4 decades later, in 2010, they said that sodium bicarbonate has no role in cardiac arrest. Since then, we have, as clinicians, we have been still practicing the guideline of using sodium bicarbonate in cardiac arrest patients. Even 2025 guidelines of American Heart Association says that there is no need for the routine administration of sodium bicarbonate. So what about lactic acidosis? Lactic acidosis, again, there is no role of sodium bicarbonate, but in a very specific scenario, the surviving sepsis guidelines has given a specific scenarios where you have to use sodium bicarbonate. That too, when you have a bicarbonate of less than 5, your pH is less than 7.1, or your patient is having a metabolic acidosis because of acute kidney injury. So the best data which can corroborate the surviving sepsis guidelines is this landmark paper, the Bicarb ICU trial, where the patients had a pH of less than 7.2 with a bicarbonate of less than 20 and a lactates of more than 2. And the average lactates were around 5 to 6 in this subset of patients. So it is an open label multi-center trial, almost consisting of 400 patients. And most of these patients has a primary diagnosis of sepsis. And it also included hemorrhagic shock and cardiac arrest. What they have seen is the 28-day mortality in this subset of patients, and what they have seen is there is no difference in the mortality between the two subset of patients. So that begs, but if they have seen the secondary outcomes, when they have seen the secondary outcomes, the patients who were treated in the bicarbonate group had a less need for renal replacement therapy when patients who are in the control group. So what they have concluded is that it doesn't improve there is no mortality benefit, but the patients who are treated with bicarbonate has less RRT days. So this is again further corroborated with this trial, the recent trial which is released recently, the Bicarb ICU trial. This is a randomized trial where they have seen specifically the role of sodium bicarbonate in metabolic acidosis due to acute kidney injury. Again, there is no difference in the mortality between the two groups, and what they have seen again is that the patients who are treated in the bicarbonate group has a less kidney replacement therapies when compared to the control groups. So overall, if you see the bicarbonate when used in metabolic acidosis because of acute kidney injury, you can decrease the kidney replacement therapy. And also in this trial, they have seen that the incidence of catheter-related bloodstream infections were also less because of the less use of because of less incidence of use of renal replacement therapy. So what about in diabetic ketoacidosis? The American Diabetic Association 2024 has issued a guideline that there is no role of bicarbonate in diabetic ketoacidosis until unless your your pH is less than 7 and you are anticipating a hemodynamic compromise. So similarly, the guidelines by the Joint British Diabetes Society for Inpatient Care in 2022 also said that the metabolic acidosis in DKA should be solved by intravenous fluid and insulin and not by bicarbonate. So what about in rhabdomyolysis? Again, no role. The ATS guidelines suggesting that the use of bicarbonate has no role in rhabdomyolysis, either in the prevention of the renal injury or in the recovery of the renal injury. So NAGMA, we all know that it is indicated, even though there are no much trials and guidelines, but the physiological aspect of NAGMA, if you see, it is just that there is a loss in the urine and the GIT, and thus we are replacing it. So it's very much indicated in this. So why are we so much worried about bicarbonate or indiscriminate use of bicarbonate? Is because bicarbonate is not without side effects, and bicarbonate should be used when the benefits outweigh the side effects. So if you see that the main problem is bicarbonate is the neurological dysfunction. If you have a severe metabolic acidosis, the organic acids won't penetrate the blood-brain barrier. But when you give bicarb, the increased CO2 penetrates into the blood-brain barrier, causes alteration in the CSF pH, mainly the acidosis, and they may cause neurological dysfunction. So the other problem with sodium bicarbonate is it causes cerebral edema. So not usually seen in the adult population, but mainly seen in the children and young adolescent. So this bicarbonate causes cellular injury, cellular hypoxia, which leads to cellular injury, and this may cause cerebral edema. Another important aspect is the altered pH. Altered pH usually causes vasodilatation and may cause cerebral edema. So there are many other problems. There are a host of other problems with the use of bicarbonate, mainly the intracerebral acidosis, paradoxical intracellular acidosis, and also many other problems like decreased ionized calcium and so forth, hypernatremia, pulmonary edema, and so on. So you have a number of host of side effects of use of bicarbonate. So that's the reason why we need to stick to the guidelines whenever we are using a bicarbonate. So where are we at this point of time? Where are we placed regarding the bicarbonate use? So despite the guideline restrictions, sodium bicarbonate has been overused in clinical practice. It has been overused. There is no doubt about that. And the sodium bicarbonate to treat metabolic is more of an intuition rather than the benefit of this sodium bicarbonate in that particular clinical condition. So there has been an overuse of sodium bicarbonate in clinical practice, and the way we need to curb this overuse is by sticking to the guidelines. So again, if see this study, last study which I am taking 1 more minute. So if we see this study, this data here, they have used bicarbonate in lactic acidosis and ketoacidosis, 2 conditions where we should not use bicarbonate. If you see here, 86% of nephrologists and 67% of critical care physicians were using bicarbonate in lactic acidosis, and 60% of nephrologists and 28% of critical care physicians were using bicarb in ketoacidosis. So definitely there is an overuse of bicarbonate in our ICU, and the only way to curb this is by sticking to the guidelines. So to conclude, empiric use of sodium bicarbonate in patients with non-toxic cause of metabolic is not warranted until unless it is a selected scenarios. And despite the guidelines and restrictions set by professional medical societies, sodium bicarbonate has been overused in clinical practice. So stick to the guidelines. So don't go with the opinion. Even Donald Trump has the opinion that he solved the India-Pakistan war. So stick to the guidelines and not to the opinions. Thank you very much.